Hello, everyone. This is Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and you're listening to EP Talk, a place where emergency physicians come to talk about things that are important to us, both sometimes professional and sometimes personal. And today we're going to be having a discussion of syndromic testing in the meningitis encephalitis, and my guest is Dr. Este O'Daniell, Medical Director of Emergency Medicine at Driscoll Children's Hospital in Corpus Christi, Texas. Welcome to the broadcast, Dr. O'Daniell.
Thank you for having me.
We're going to jump right into this because, syndromic testing is kind of a term that not everybody is familiar with. What is syndromic testing? Infectious disease testing for detection of meningitis encephalitis. What is the
right? Yes.
How do you characterize that?
Right. Yes. Thank you for asking, because I do think that is a term that not everyone would understand necessarily. So I'll explain just a little bit. So as everyone knows, a syndrome basically is a group of symptoms that occur together. And so syndromic testing is where we use a test to simultaneously target, say, multiple pathogens that may be causing that syndrome or that constellation of symptoms that we're seeing. So, when an emergency department patient presents with this constellation of symptoms, our job is to determine, does the patient have an emergency medical condition? What is the diagnosis, and do they need to stay in the hospital, or are they able to go home? So those are the questions we're trying to answer by using a syndromic test.
You and I both have been practicing emergency medicine for decades, and so the big question when you're looking at meningitis encephalitis is, first off, does that headache, does that fever, does that minimally stiff neck, what do they say? If you think it, you need to do it. The lumbar puncture, and so. Especially when you're dealing with children, as you have been for the last several decades, why would an emergency medicine physician use a symptom-driven test as opposed to the alternative methods for diagnosis?
Right. So, anytime you have a constellation of symptoms, especially when you're talking about meningitis or encephalitis, and with infants and children, sometimes they will present in a different way than an adult would, for example. So they don't always show the same signs and symptoms. Their fontanelles sometimes are open. They may not have meningismus. They may not have as much vomiting as you would, and they can't communicate with us. So we would want to use something like this because early on in the course of an illness, whether it's bacterial or viral, it may be difficult to tell exactly what's going on, and you may have to have a high index of suspicion and use this test in order to rapidly identify what sort of pathogen you're dealing with.
Yeah. So it seems like you have two large questions in syndromic testing for meningitis encephalitis. So first off, are they sick at all? Okay. That when you do a lumbar puncture and you get the results back. But the second one, which is absolutely important, is it viral or is it bacterial? And I think that with this looking at multiple etiologies, you're able to get a better idea not only of just the severity but also of the pathogen. So, give me an example. How has this technology impacted patient outcomes in suspected meningitis encephalitis? What are the pros and cons of this approach relative to the traditional way of doing things?
Right. So traditionally, we would do a lumbar puncture, take the spinal fluid, send it to the lab. The patient would be started on broad-spectrum antibiotics, which is still something that we will do sometimes initially, especially if the patient looks really ill. However, we don't have to wait as long now to determine what exactly is happening with the patient. Some patients can come in, say, with the same signs and symptoms as I mentioned earlier, vomiting or fever, and maybe even a stiff neck if they're a little bit older, if they're an older child. and you're trying to determine, is it bacterial or viral, as you mentioned. And so, you can start them on some IV fluids. You can get them some antibiotics if they're really ill, send off the syndromic test, and then within a matter of a couple of hours, you're able to rule out whether it is depending also on your TAP results, whether it's a bacterial or a viral entity, and you're able to sometimes even send those patients home, depending on how they look and what sort of identification you make. If your gram stain is negative and you've got, say, an enteroviral infection, then and the patient's doing well, they just need pain medicine and sometimes antiemetics that they can go home with, and they can do a 24-hour follow-up with their primary care physician. So definitely beneficial.
Yeah. I want you to back up and repeat something you just said. Within a few hours, are you telling me that you can actually send a kid out within a few hours and know that?
So yeah, I have had circumstances where I have a young patient who comes in, with headache and vomiting, concern for meningitis. We do the lumbar puncture, send off the spinal fluid. We get maybe a low white count, and so you're suspecting that it's a viral entity causing this, a negative gram stain, and then within an hour to 2 hours, you have your film array, your biofire panel that comes back positive for, say, an enteroviral infection, and you can be pretty confident that that patient has a viral meningitis. And if they're looking good, I have sent patients home from the emergency department within a few hours, doing much better, and also the peace of mind that it gives the family, and the nail biting that goes on when anybody's worried about somebody having meningitis.
Absolutely. No, I mean, I've been a parent and now a grandparent, and the thought of your child going to the ER with a fever, and even as a clinician, we always is that nuchal, is that meningismus or is it not? My wife looking at me and going, what's your best guess on this? And of course, in the past, what we did was we loaded them up. We loaded them up with antibiotics, and we waited until sometimes cultures and at least gram stains, and you never knew whether it was the right thing or not. And now you're saying that within a few hours you can have a really, really confident diagnosis, and that's amazing. So when you look at that, there's benefits for patients. There's also benefits for your institution. Talk about that a little bit.
Absolutely, yes. So our studies, the studies that I've reviewed, and anecdotally, not only anecdotally, but the studies also show that decreasing the use of broad spectrum antibiotics is a real thing. We've been able to contribute to antibiotic stewardship by not continuing broad spectrum antibiotics in the cases where, say, a patient does need to be admitted, for example, because they continue to have vomiting, but it isn't the bacterial pathogen causing the illness, then the antibiotics don't have to be continued. There have been studies showing decreased length of stay in the hospital as well. And then, of course, as we mentioned already, or as I mentioned, decreased time to diagnosis, and specific organisms being identified pretty quickly. So this really puts the parents at ease, as I mentioned, and also the physician, because, I'm always worried about my patients. I want to do the right thing for them and treat them accordingly. So it definitely is some cost savings to the institution and the families.
We're talking generically about syndromic testing of meningitis encephalitis. Is there a specific test that you personally use, that you can not asking you? Well, I guess I am asking you to recommend it. What syndromic test panel do you use at Driscoll? And tell me a little bit about the one that you use.
So we use the BioFire film array panels. We have all of their panels here at our institution. The ones that I specifically use in the emergency department are the meningitis encephalitis panel. I also use the GI PCR panel. for diarrheal illness. It is just an amazing panel as well. We've had a lot of really good results. We're able to identify bacterial pathogens that need to be treated, and then especially in the course of a patient having bloody diarrhea, everybody's worried about that as well. And being able to identify that quickly. And then also we use the respiratory PCR panels here quite often. So, they identify multiple pathogens, and so all of those have been very beneficial to us. And then our inpatient units in our ICU, they use the pneumonia panel frequently, and the blood culture identification panels, I believe, they use those as well. So very great tests that we have available here at our institution to help us treat our patients the way that they should.
And that's BioFire film array, and that's I'm not sure, I may be stretching your knowledge of exactly how that works. Is that a antibody assay?
It's a PCR panel. So yes, you definitely I am not able to explain the details of that, but our pathologist could probably do so. But it does work. I can tell you that.
Well, that's fine. That's fine. I was asking you because I have heard about BioFire film array, and I just was thinking, okay, what is it? It's polymerase chain reaction studies. Okay, that's what they
Correct.
are. Okay.
Right. They are PCR. They are not antibodies. Right.
They're not antibodies. That's the key there, which actually makes it more specific, which is to your benefit. Are there any publications that you recommend that you want to learn more about syndromic testing generally and BioFire specifically?
Well, yes. The BioFire website does have quite a few studies listed there. I specifically have reviewed quite a few of the current pediatric journals. Pediatric Infectious Disease Journal is one of them, the American Society for Microbiology, Hospital Pediatrics through the AAP, and then some other European studies. And I would be happy to send you the references if you'd like to link them in any way.
Okay.
But the good thing about those is that they're all specific to peds. So those were all pediatric studies that I reviewed. So as a pediatrician, a lot of studies we have to generalize to peds, and they're not always just little adults. They do have their own specific ways that they present. Like I mentioned earlier, sometimes their fontanelles are open and they're not going to present with the same signs and symptoms. So it's good that many of these studies are specific to peds.
Yeah. In the era of COVID, being able to say something is negative predictive value. In the era of COVID, being able to negatively predict the outcome of a test is probably as important as positive, because I'm not speaking of COVID specifically, but the idea of being able to say, no, you don't have bacterial disease. You don't have the kind of disease that's likely to spread like wildfire and have a high lethality to it. So, when I think of these syndromic testing panels, I think of them being able to reassure parents. And I would assume you would agree that the negative predictive value is probably as important as ruling something in, no?
Absolutely. That is golden. It is so important to be able to rule something out and to say this is not this, that we were worried about. This is not a bacterial entity. Additionally, to kind of go along with what you were saying regarding COVID, our viral panel, we are very grateful to BioFire because they have included the COVID test in that viral PCR panel for us. And in doing so, we can be very confident if it comes back negative that it's not that. So we're very grateful to them for that. And yes, it is really important to say, this is not a bacterial infection.
Yeah, yeah. I know the number of times that I've gone back to talk to parents and have just seen the drain from their faces when I tell them no, the test is negative, and we're pretty confident that this is not going on, and you're going to be able to go home. It's just like you've lifted a giant weight off their shoulders in being able to do that and be confident in that. How many times do we just give them good news that no, you don't have X, and because they come to us with all the fears and so negative predictive value is incredibly important. Now this is we talk about this almost in the abstract because you're the one that you've been using it probably in your emergency department for quite some time. But go back and tell me, walk us through the steps of, let's say, a hospital director who's hearing this for the first time and says, I can do that, but how would I get my hospital involved? Had you hear about the technology and why did you decide to implement it, and what would be your advice for how to implement syndromic testing with this?
Yes, sure. So our hospital has had this, as you mentioned, for quite a few years, and we've been very fortunate to have this available. It has impacted my practice here, and I don't think I would want to practice without it because I do feel the patients receive better care because we do have this available. So having said that, I think your first step would be to review the literature, of course, and then next step would be if you have an infectious disease specialist that you could discuss this with, your pathologist, your lab department as well. And pretty much once you review the literature, it does sell itself, to the C-suite, which is, where one of the hurdles you probably have to jump. It definitely decreases the use of your broad spectrum antibiotics. The studies have shown that it can decrease in pediatrics specifically, decrease the use of antivirals as well, because many times we start acyclovir on these little patients, and sometimes they have to be on that for some period of time as well. It decreases your time to diagnosis and your length of stay. So it's a win for the hospital as well, in addition to providing better care for your patients. So that's how I would get started, working in that direction. And I don't think that anybody would have a real tough sell getting the hospital to bring this on.
You've talked about the circumstances that you would use it for. Are there situations that you would not order it for? Give me the kind of the negative side of this.
Yeah, I almost always use it in the patient that is very ill appearing, and I'm concerned for meningitis or encephalitis, because your pretest probability is pretty high that you're going to have a meningitis, and they're likely going to be admitted anyway. So if they're not turning around right away and they're probably going to be admitted, I'm going to go ahead and get this immediately ordered so we can get a quick identification. If I'm doing an LP for other reasons, say for example, I'm looking at, say, a patient with pseudotumor cerebri or like a bleed that we're concerned about, or other reasons, then I may hold off. If it does look like it's meningitis or encephalitis and there's a lot of white cells there, then of course I would send it off at that point. But sometimes we'll hold off on those circumstances in using it.
Are there any circumstances that you find that where the result is difficult to interpret? Anything? How would you handle that?
I haven't had any difficulty at all with results interpretation. It's pretty easy. The meningitis encephalitis panel targets, I think it's 14 pathogens, and it lists the pathogen and is it positive or negative. It lists them all and basically tells you what they have, so yes or no. So it's very simple. The GI panel is, I think, 22 pathogens, and the respiratory panel, I believe now with the COVID, is probably 23 pathogen. So it's very easy to interpret.
Good. Okay, that's good news. Actually, the last thing you want is to get a test where they promise you that it's clear cut, and it's never clear cut, and it's always in the middle. And it really, I mean, how many tests do we have now that we think are going to be definitive, or you get I mean, COVID's a good example. I mean, we've gotten tests now where we think that they're false negatives are 30%, and so you end up just treating them on their syndrome regardless. So the idea that you can pretty well rely on the results of the BioFire as panel is pretty encouraging. Give me an example. We're just about ready to conclude here. I'll let you give some information about where people can follow up with here in just a minute. But give me an example of a case where the panel really changed what you were going to do. I mean, not necessarily surprises, but unexpected results maybe.
Right. So, so I had a patient one time. It was an infant. Again, this kind of goes back to the example that I gave earlier, but this was a little baby. And this little guy, he actually, he was vomiting and he had fever. We had a high index of suspicion that he could have meningitis because some of our labs came back with a really high inflammatory markers, like a CRP was elevated. So we proceeded with the full the panel. The little guy ended up having a viral meningitis. So while we started acyclovir initially on this baby because of his age, as well as broad spectrum antibiotics, we were able to stop those immediately after we got this result. We ended up admitting him because he did continue to have some persistent vomiting. He just wasn't feeding as much as we would have liked, but we did not have to continue those antibiotics. And he was able to go home after I followed up by the next day. And so I know that the doctors on the floor felt very confident with the result and the negative gram stain. And once he was able to feed and tolerate, once he got a little bit better hydration in him, he just perked right up and was able to go home pretty quickly. So he didn't have to stay until, our cultures were negative. And that used to be at least 48 hours of inpatient antibiotics and length of stay. So he was able to go home in less than 24. So
that's I can tell you his mother remembers you as subsequent children might be named Estella.
Yeah, they were very relieved, and there's nothing better than being able to go and talk to a family and reassure them, and give them a hug and say, your baby's going to be okay. It's very difficult when you do identify a bacterial pathogen, and it does help in that regard as well, because you can also advise the family and say, this what it is, but you really can't predict at that point how the outcome is going to go. So, it's helpful both ways. And, I just would not want to practice in the emergency department without these panels. They really help me on every shift. I'm able to help someone in a better way because of them. So.
Yeah, we're becoming more and more aware of the dangers of high potency antibiotics in our general culture. They're coming at us from every angle. Antibiotics are coming at us from every angle, and the result is that we're having to administer stronger and stronger, broader spectrum antibiotics, and they are not without their problems, their long-standing problems, and so. Being able to identify make the right diagnosis and get people off of antibiotics quicker or avoid them altogether has a lot bigger outcome, a positive outcome that you might actually think. You might think, oh, that it's great that we can relieve their stress or their concern, but to also get them off of these high potency antibiotics is a huge positive, just to our practice, to our patients, to their later lives,
Absolutely.
I mean,
yes, I agree.
so,
We're learning more and more about that every day.
Yeah. So anytime that we can come to that diagnosis quicker and either avoid or limit these antibiotics for especially the little ones, I think that we've moved the ball in a very, very positive way for these kids and for their families, for that matter. So Dr. O'Daniell, thank you for joining us, and thank you for talking to us about the BioFire meningitis encephalitis array of panels that can help you do that. If people that are listening to our broadcast today want to get in contact with you, may they do that directly, or is it through? How's the best way to do it?
Yeah, I can leave you my email address if you'd like to have that. I'm happy to do that. I'm happy to communicate with anyone that has any questions for me specifically about pediatrics. Sure.
Well, you've given us food for thought, giving us the publications to deal with. But I was just thinking of if anybody has specific questions. I don't want to make you the nationwide 911 call for children with meningitis encephalitis, but I do. Sometimes people do want to pick your brain with a question that maybe I didn't think of, and I'm sure you'd be happy to answer that. So, thank you again for joining EP Talk. It's been incredibly important talking about meningitis, encephalitis, syndromic testing, especially using the BioFire array. And I hope that those listening today will think about it. And if your hospital doesn't have these kinds of diagnostic testing, you might want to think about it, because as we've said, it's good for your patients, it's good for your institution, and the more we know about antibiotics and their long-term effects, it's actually good for patients at large. So this is pretty important. It's not just the individual patient that we're concerned with here. It's going to have huge impact. So thank you for joining EP Talk, and join us again at our next time. This is Mark Plaster signing off for EP Talk.